I'll get started. My name is Monika Jones. I am not a doctor. I am not a physical therapist. I am not a physiatrist or an orthopedic surgeon. I'm just a mom who started an organization that works with children who've had epilepsy surgery to stop seizures. And one of our core initiatives is understanding rehabilitation after big procedures. So if you don't think you should be in this room, it won't hurt my feelings if you leave. But we are the only organization that's looking at outcomes after surgery beyond seizure control, as well as how to improve them. I would love to know if everyone here has had a child who's had surgery, or if you're considering it, or I'm even open to, okay? Do you want to tell me what kind of surgery you've had?
I had hemispherectomy surgery back in 2012.
Awesome. My son had a hemispherectomy in 2007. Yeah, great. Okay. If you want to share.
Okay, in December I'm getting VNS.
In December you're getting VNS treatment. This might not be the best session for you, because we're really going to talk about epilepsy surgeries that go into the brain, not on the VNS, on the vagus nerve. Okay. Does anybody else want to share? Yes?
In January I'm going to have brain surgery.
You are.
Be doing the phase 2
Okay.
and determine whether I'm going to have a resection or ARCs.
And do you know where you're going to have a resection, and what part of the brain?
The parietal lobe or the temporal.
One or the other. Okay, great. I'm going to write that down. Anyone else? Yes.
We're just in the process, I guess, of doing the surgery assessment.
Okay.
So just wanted to get some information.
Our daughter's in the process of starting the generic process of life.
Okay. And how old is she?
5.
She's 5. Okay. 5. Anybody else? Yes.
We came a little late. What exactly are you sharing?
I'm just wondering if anyone is, their child has had epilepsy surgery, or you're thinking about it.
She
Yeah.
had her hemispherectomy, right hemispherectomy, 7 months ago.
7 months ago. 2 hemispherectomies in the room. 3 if you count my son. So another hemi. All right. And we're cheating because we know each other, right?
Emery had a hemispherectomy when she was 6 months old.
When she was 6 months old. Okay. So what I'm first going to talk about, it's going to be totally impossible for us to cover everything in this 1-hour session. The brain is a tremendously complicated organ, obviously the most complicated in your entire body. What I'd first like to just talk about did you want to tell me what your daughter has had, or your son, or no?
Myself.
Or yourself? All right. Yes? Temporal lobe.
I don't know what the technical term of it is, but I had it
4 years ago. Okay. I think the best thing to do is to start with what the different parts of the brain do, and that's so important for all of you to talk about with your neurosurgeon and neurologist, is what part of the brain, so for those of you that are considering surgery, what part of the brain are we thinking of touching? If you're looking at anything in the frontal lobe, your frontal lobes, you have 2. They're here in the front, and those are really what we call our executive processing centers of the brain. They are what help us with not saying something that you're supposed to, you really shouldn't say, how you initiate different things, sort of the thing that makes us very human in terms of how we function with other folks. It's also the part of the brain that tells you when to start moving, because you have something in your frontal lobe that's called your motor strip. Does everyone know what the motor strip is? Hemispherectomy moms do, right? So you have a sliver of brain if you look at your frontal lobe here, that's called your motor cortex, and it's about this big. Each side of the brain has one motor cortex. And your motor cortex is the only part of your brain that has motor neurons in it. Your brain has something like 45 different types of neurons, and only the motor cortex has motor neurons. This is really hard to do without a presentation, and I'm happy to share on our at our booth some photos and things. So both sides of the brain have a motor cortex. Do you know what would happen if I removed both your motor cortices? You couldn't move. You couldn't tell yourself to move, right? So anytime you're thinking about surgery, you do want to talk about whether they're going to touch the motor cortex. Your motor cortex neurons are the only part of the brain responsible for intentional movement. So we've all heard about Lou Gehrig's disease, ALS. ALS is a disease only of the motor neurons. So somebody with ALS still has their other capacities, right? But they lose the ability to intentionally move their body. When you look at an individual neuron, and this is a really crude representation, each neuron has what's called an axon coming off of it. You all know what an axon is, right? You know now? Your axons from your motor cortex travel all the way down. They cross over to the other side mostly. And then they go all the way down to your spinal cord when then they touch a lower motor neuron that then goes into your body. All right? If you cut this axon at the spinal cord level, you have paralysis, right? What if you cut it way up here? Do you also have paralysis? Right, so it doesn't really matter where you cut it. What does matter is here they start to bundle into different areas. So when you're talking about epilepsy surgery, you do want to know whether they're going to remove or disconnect the motor cortex, because that's going to affect your movement on the opposite side of the body. You do have connections, though, that go to the same side of the body, axons that go down to the same side of the body. So have you all heard that the left side of the brain controls the right side of the body? That is sort of true. The left side of the brain controls the right side of the body by about 85%. But the same side of the brain controls the same side of the body by about 10 to 15%. We're all a little different. So with hemispherectomy, that's why you can walk, because the same side of your brain still has connections to the same side of the body. Those connections, though, are pretty weak. So they do a really good job of controlling the muscles in our thighs, the muscles in our shoulders, because you only have 3 muscles in your thighs and something like 2 or 3 muscles in your arms. Where it starts to get really complicated is when we're looking at fine motor function in the hand and movement of the ankles and toes, because you've got a lot of muscles in your hands and in your feet. So while that connection does a really good job of controlling the shoulders and the hands and the legs, which is why most of the children in the community of kids that have had hemispherectomy can walk, they all have a lot of trouble controlling the fine motor function of the hand. We see differences not based on the amount of therapy you get with the fine motor function in the hand, but really on what happened before surgery. So if you had an insult to the brain in utero or really early on, you're going to have more function in both sides. Do we know why that is? Is everyone still with me? Like I said, this is really complicated to explain. So when you're an infant, when you're in utero, remember I said one side controls 85% and the other side controls 15%? When you're in utero, it's 50-50. So if that insult happens really early, then that other side of the brain still has that 50% connection. So we have children in our community that have had hemispherectomy as old as 17 that have lost almost no function opposite the removed hemisphere and who have no therapy postoperatively. Why do they have perfect function? It's not about what happened with the surgery, it's when the damage to the brain happened originally. And these are the kids that have really, 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 really early insult. If you're looking at a surgery that takes out the temporal lobe, so you each have a temporal lobe on both sides, you really want to think about how that surgery is going to affect hearing and listening. So your temporal lobe has a little piece in its side that is 100% responsible for listening. So if I were to remove your auditory cortex on both sides, what would happen? You'd be totally deaf, right? If I remove the temporal lobe on one side, you can still hear, but you will have problems with what's called auditory processing. This is really pronounced in a room that's a crowded environment where there are multiple speakers. So if we were all talking right now, I'd be able to look at you and we would be able to sort of talk and I could understand what you're saying based upon how loudly you were speaking, even though there were multiple speakers in the room. A child who's had a temporal lobectomy or a temporal lobe resection or a hemispherectomy is going to hear fine. They're going to pass a normal hearing test. Where they will have challenges is with multiple speakers in a room or what's called localizing or lateralizing sound. That's what we do when we're crossing the street. We look for cars, but we also hear for where the car sound is coming from. So if your child has had part of the temporal lobe removed in hemispherectomy or TPO or temporal lobectomy, you really want to make sure they have training on lateralizing sound because it's a particular danger when they're crossing the street. Yes. Why don't you guys move up so I don't have to... You should, oh, okay. That's all right. I'm used to that. I have 2 boys, so...
Do you know if she had her temporal removed in the right hemisphere and then her whole hemisphere is disconnected, obviously?
Right.
Do you know if that affects sensitivity to sound?
Yes. So we see it anecdotally on our community, and that's what we're trying to track in our registry. A lot of the children have what's called hyperacusis, where they hear things much more loudly than you or I would, or they have something called misophonia, which is they just can't stand a certain sound. So my son, for example, a fire truck, no problem. If our dog barks, forget it. He goes crazy. A vacuum, no problem. But my other son has this little horn thing on his bike that Henry can't even tolerate it. So unfortunately, that's not reported in the research literature, but it is something that we're trying to capture in our registry because a lot of families have been complaining about it. Where the concern for us as parents of younger children is, when they're crossing the street, when they're getting to that point. And then also, when you're learning how to read, reading is also primarily an auditory function. So it's a visual function as well as understanding the sounds that letters make, right? That the P makes the P sound, but the F makes the F sound. If your brain can't process sound well, then it's going to be challenging learning how to read well. So you want to make sure services always increase for the child in school to accommodate for that and make sure they're being taught in a quiet room so they don't have a lot of interruption from other speakers. The temporal lobe also is, on the left side, is primarily where language is lateralized. However, in a child with epilepsy, you may have language lateralization on the other side of the brain. So during your epilepsy surgery evaluation, you want to have some sort of an assessment that's looking at where the language function is right now. Your child is 5? Right. So they can do something called a WADA test, but if she can tolerate it, there's also something called a functional MRI. And that they'll put her in an MRI and they'll say this word and say that word to see where the brain lights up if she can't tolerate the WADA, which is invasive. to see if they can capture where her language is. Most of us have language on the left, about 5% of us have language on the right, but you generally throw those rules out the window in kids with epilepsy because the number one thing your brain wants to do, aside from helping your body move, is talking, because we're human. So the brain quickly tries to figure out where else to put language when you start to have epilepsy in your temporal lobe. Talking about the parietal lobe doesn't have any what I would call upfront functions like the temporal lobe or the occipital lobe has, but it's involved in what we call the dorsal and the visual stream, which is the pathways from other parts of the brain that control various parts of things through connections. You're all free to look at this card. It's an artistic representation from an actual MRI using microsketchings of only 500,000 neurons, and your brain has 80 billion neurons in it. So you can see here on the outside, those are your that's your cortex, those are your neurons, and these are your connections, your white matter. So when you look at the parietal lobe here, you can see how it's connected to so many other parts of the brain. And these connections, we're only looking at a slice this way, but if you were to look at a slice the other way, you'd see that some of these connections go across. So when your occipital lobe sees something and that sends a message through the parietal lobe to the frontal lobe to move your body to get out of the way of whatever you're seeing. So if you have surgery to the parietal lobe, you may have an effect on that pathway unless the brain has tried to figure out a different pathway beforehand, right? Does anyone have any questions so far? No? So this session is supposed to be about rehabilitation. My job is really easy because there's really very little research out there about rehab. There's not a single published research paper about rehabilitation after adult epilepsy surgery, and there's only about 5 published papers on rehabilitation after hemispherectomy, for example, and our organization funded 2 of those, so the other 3 were from other scientists. So the best that we can do when there's not research in your area is you back up into other areas. So what we do at our organization is back up into the world of cerebral palsy or pediatric stroke, and in the adult world you would back up into the world of cerebral palsy or any kind of therapy for cognitive issues. Generally, the rule with any kind of rehabilitation is repetition, repetition, repetition. So any kind of therapy where the message is repetition, repetition, repetition would have some sort of a research basis to it. So let's do that for first. The first is repetition. The second is intent. I hate golf. You couldn't pay me $1 million to become a good golfer. I hate it. I don't like going out there. I think it's really boring. So I could repeat my golf instruction 100 times a week, and why am I never going to become a great golfer? I don't have the intent. So whatever therapy you do with anyone has to have that intent. My husband loves to golf. He loves it. He does a lot of repetition and he has a lot of intent, so he's a really great golfer. He also has the skill for it, which is important. So when you're looking at any kind of rehabilitation, you want to look for the repetition piece and the intent. In rat research, when they do big resections, one thing that does help is brushing. So rats that are brushed several times a day recover better. Why is that? Sensation in drives motor function out. So if you're brushing the skin, it's going into your sensory strip, which is then telling your motor strip to drive function out. Does that make sense? The fourth thing is complexity. So a complex environment increases functional outcomes. Rats that are in really complex housing versus rats that are kept just in a box after these surgeries do much better than the rats that are in a box. The more complex the environment is, the better off. So that means if you have, for us younger parents of kids with younger children, again, there's not research out there, so the best we can do is back up into these other areas. School, I know a lot of us don't want to send our kids to school because we're worried about their safety, but school is a complicated environment to learn to start to navigate. You're kind of getting inundated with a lot of, teaching and things, taking them to the park constantly. Do you know that a toddler walks the length of 2 football fields every day? Every single day. So when you have a kid who's had surgery that affects the motor output so much, you want to get them into a situation where they're walking as much as humanly possible. And you're really not going to get that in a typical physical therapy session. So what a lot of doctors will tell me is don't take your kid to PT, take them to the park for 3 hours or get them involved in sports where they're running all the time because they're getting that movement going. When you operate on the motor strip, so if you're looking at a frontal lobectomy where they're, go ahead.
Sorry.
Yeah.
Going back to the complexity, my daughter is 16 months old and still isn't standing on her own. She's getting there.
Yeah.
Obviously can't walk. Can you describe or give some advice on our house and how we can create an environment for her where it's more complex so that she's getting the most out of it? Because right now we have like a big playpen for her.
Yeah.
We let her kind of crawl around. We have a ton of toys. She's constantly playing with toys and doing that. But
Right.
because she can't walk or anything, I mean, that's kind of like the best we feel we can do for her.
Right.
Do you have any other advice on how we can set up our house to...
So what I did is we closed off one of our entire floors just for my son, removed anything that would be an obstacle, wiped down the floor with rubbing alcohol so that it was clean, which we have dogs, so it was never really clean, and then left him on the ground all the time. So I have this great book called Cerebral Palsy in Infancy is kind of our Bible in terms of rehab for small children, and generally you develop from the torso out, so babies first start to have trunk control, then they have neck control, then they start to work out, kind of working out. So you want to really develop that back control and the neck control. If she can't crawl yet, can she crawl?
She did.
Yeah. That's great. Yeah. Getting every possible opportunity to crawl. I think we like to, we want to keep them in the stroller to keep them safe and that. Get them out as much as possible and get them on their tummy so they can crawl. I know that's a challenge for you with your daughter's G-tube. But again, it's that repetition and then that intent. So are the toys in there the toys that she wants to get to? Part of that intent is also mom and dad getting out down on the ground with her. She's going to crawl to mom and dad way faster than she's going to crawl to a ball she doesn't want to get to. I know that's hard in reality to do that. If there's a sibling that's willing to play with her or a babysitter down the street that'll come in for an hour or two, that's really what you want to start doing in the beginning. For you guys with a daughter so young, brushing her, sensory in is function out. Just keep thinking of that loop. Yeah. Yes.
You said about the brushing.
Yes.
What exactly? How?
Like with a baby brush, so because it's soft and it's not going to hurt the skin, so that's enough. So remember I talked about your motor strip? Right next to your motor strip, you also have what's called your sensory strip. Your sensory strip is the only part of the body receiving sensation in from the body. Motor strip drives function out. Sensory strip senses sensation coming in. So you want the sensation to come in, they're close for a reason. Because as soon as this sensory strip feels something, like fire on your finger, it's going to tell your finger to pull away really fast. So you want to engage that more. Yeah.
Any part of your body, just the brushing.
Just the brushing, right. Now that's what it says in rat research. You know, I can't assure you that it will work in adults, but we really, you know, nobody's really focusing on this. So the best we can do is go with what's out there so far. Yes.
Just because I'm a little confused.
Yeah, because it's confusing.
Sensory motor cortex?
Yes.
Is that like in between them? Or?
No, so a lot of these terms are thrown around. This is technically your motor. This is technically your sensory. Sometimes they're put together, like the doctors will talk about your sensory motor cortex. Yeah, yeah. Or they'll call this the sensory motor cortex. This is definitely your motor cortex. Yeah. If you've had hemispherectomy, if you've had frontal lobectomy where you're removing the motor strip, now you want to avoid spasticity and contracture. So most of the messages coming from your brain are telling your body to stop moving, which is interesting. When you've cut one motor strip out, now your muscles are getting more the message that says move, and what that does is make the muscles start to contract. So over time, so you've all seen someone who's had a stroke. Over time, the hand starts to come up. You really want to avoid spasticity and contracture as much as possible in our kids, and you do that with at least 8 hours of stretch per day. That's the rule. How you get that stretch is going to depend on the child. So either you do the stretch, let me tell you it's really hard to stretch for 8 hours a day, or the child wears an orthotic. And that orthotic is going to stretch the foot into the right position, is going to stretch the hand into the right position, because what you don't want to have happen is it to develop into what's called contracture. E-stim, I see your son, that's also another method to avoid. Right, and right. So my son has had all of it, and eventually we did develop contracture. And contracture is basically your muscles are now so spastic that they've developed a case around them that can only be released with surgery. So if you've had hemispherectomy, if you've had anything removing the motor strip, you want to try to avoid contracture as much as possible. Yeah. Are you looking at an occipital lobe removal?
It's a temporal, it's not a removal, it's just vocal epilepsy.
Uh-huh.
So it's a certain spot. I don't
Just
know.
a hot spot.
Yeah,
Yeah.
but then it says on our MRI, I guess it goes into the right sensory motor cortex.
Okay, right. So she may have trouble with motor planning. Right. So, and so we see that a lot in children who've had surgery to the temporal lobe. They have some motor planning problems. They want to move, but they can't figure out how to do it. So the post-rehab should be focused on that planning portion of rehabilitation. And it's really hard to say because some kids don't have an issue and some kids do. We don't have enough data on it. Any other questions? This is really easy because there's no research out there, so I'm just doing my best to tell you what we know so far. Yeah. Yeah, so what I was saying before is your parietal lobe seems to be more of a pathway to other parts of the brain. And it really depends on where in the parietal lobe they're going to resect. So some of the pathways, it's called the what pathway. So for example, the what pathway or the dorsal pathway from the occipital lobe, your occipital lobe will see something and then it tells your parietal lobe what you see. Your occipital lobe may see something and then it takes the ventral stream the other way to tell you where you see it. So you do want to talk to the surgeon about which pathway might be disrupted from the surgery, because then you may have some challenges naming things after surgery or identifying where they're located. Yeah. So you might say, that looks like something I know, and someone might have to remind you, that's a purse. Oh, now I remember, right? Because it's been a disruption to that pathway. Or, I see the purse, but I can't tell you where it is. It's right over here under your mom's foot. Ah, now I understand. So the where pathway was disrupted.
What strategies should the people be doing for the hemianopsia?
Right. So hemianopia is an unavoidable side effect of removing the occipital lobe in its entirety. You cannot get that lost visual field back. I don't care what anyone says. We're really careful at our organization about using terms like rewire or neuroplasticity too loosely. I can tell you that if you cut the axons in your brain, they do not rewire. They are permanently cut. And we want them to be permanently cut in the world of epilepsy surgery, because if they grew back, we'd have a big problem because your seizures would come back. So it's brain 101 to know that central nervous system axons do not grow back. Neuroplasticity really means the ability of these neurons here to figure out a workaround from this cut part to see if they can take over functions through existing connections. However, if the connection is gone, like with the motor strip, no matter what workaround you have, you're never ever going to get that fine motor back. You're just not. It really depends more on how the connection looks before the surgery. And there's actually research that shows they do DTI, MRI beforehand, and the kids that have more of a connection before have better function after. So going to your question about hemianopia, you want to make sure that the child has compensatory mechanisms, right? So the orientation and mobility specialists' evaluation at school should be looking at how you walk around in an environment that is static, meaning no furniture is moving around, everything looks the same. How he is doing in a dynamic environment. So a dynamic environment is where, like out there, a bunch of people moving around, right? It's very different than in this room. How he's doing in a familiar environment, like your home or a school, and an unfamiliar environment, like a school you're about to go into. Maybe you're going from 8th grade into high school. So 4 different ways they have to evaluate. And it's our position you should have orientation and mobility throughout the entire school experience, because school changes. I would also explore whether using a white cane out in public is appropriate. Perfect. Very few. Bye. Thank you for coming. Yeah. It's tricky if you've had a hemispherectomy because you've lost so much of the fine motor function in the other hand, so now you've only got one hand. But having hemianopia out in public, very easy to bump into other people, and it's an invisible disability, right? So no one can tell that you've lost quite a bit of your vision unless they know you and understand the visual field loss. But I know a lot of adults who've had the surgery in childhood and they don't want to use a white cane. It's personal. You're a teenager, right?
Right.
You're probably really stubborn. Yeah? Oh, good. That's good to know. That gives me hope. It gives me hope. That's great if you're using a white cane, because we've had a lot of adults who've had surgery in childhood who talk about just bumping into people or tripping over things because right into him. So that white cane is more for cueing other people that you have the visual impairment. Yeah. Any other questions? I know this is a lot if you're just considering surgery. If you're having a tiny piece taken out, you shouldn't have too many impairments. I would ask exactly where in the temporal lobe are they removing, especially if they're near the auditory cortex, because then you're going to see some hearing and listening issues, which for a kid learning how to read can create a challenge at school. And then if you know that, then you know that services are supposed to go up. and go onto our website. We provide advocates for you in school after surgery. We provide free school training so that the school understands the impairments. And we'll come in and train the school team either remotely or one-on-one if you're close. Yeah.
What's the area?
We're in Los Angeles, but we do the training virtually. Yeah. But I'll do live training in LA.
On your packet, in the Brain Recovery Project, the education after hemorrhage.
Oh, do you have that?
Awesome.
Oh, good. Oh, good. I'm glad.
Copy it for every
Good.
single new person that he has.
On our website, we have a lot of downloadable guides for you and the school team, and we have one called Education After Hemispherectomy. Now we have school presentations in the can, I call it, so depending on the side. There's also been a lot of research, and we have had 2 research meetings since we published that. For example, IQ tends to go up, but it goes up over time. So a lot of times the schools will say, here's where you are now, so we're going to put you in this class. Well, what they really should be doing is reevaluating every year, because you're going to start seeing an uptick, right. Reading intervention also, that reading intervention needs to be intensive. Yeah. Yes.
Doctor said that he's not going to perform WADA test on her.
Uh-huh.
So what is that?
WADA test is named after a doctor. Her last name was WADA. It's called an intracarotid, I should know this by heart, something barbital test, where they inject a tracer into the brain, and it actually puts one side of the brain to sleep. So it would completely put her left hemisphere, it would disable it. It's invasive, so they have to insert a needle. I think they do it through the, did you have that done before your surgery? They go through the groin, they knock out one hemisphere, and then they see if you can talk and what you can say. And that will show if language either transferred over to one side or if you always had it on the right to begin with. Yeah. Yeah. It is not something you do with younger children because it's hard for them to tolerate a big needle in the groin, so we encourage functional MRI. She could also have a functional MRI.
Maybe that, anyway, the doctor said that he would skip that. No.
Yeah, I don't think so if it's in the parietal lobe, you know. It's really that,
The location.
yeah, that would really be more of a left temporal lobe thing. Yeah, yeah. Are you still getting O&M in school?
Yes.
Oh, good. Do you live around here?
We're in Boston.
You're in Boston. Oh, nice. You should check out Perkins School for the Blind for your assessments there. Oh, good. I'm going to be there in 2 weeks. Yeah. We do we're part of a big collab with them for cortical vision impairment. So, yeah, they're great. That's where I would go to for all vision assessments. Yeah. Anybody else? Oh. What do you say? What question do you have, buddy?
For the evaluation part of it, obviously, you want to try to be an advocate to get the surgery as soon as possible. What kind of things, as far as like getting it, when you talk to them ahead of time about the surgery, but how do you get those other services you're talking about in place so that you don't have to do that after the surgery?
The school?
But yeah, I'm just saying, like, anything that you need as far as, like, what is places that I can go to find out, like, how to start that stuff so it's already there when the surgery is done versus having to kind of figure it out.
So it can't be there once the surgery is done, because if you're talking about school services, they have to do evaluations beforehand to see what her needs are. If you go to our website, we've got a ton of resources for you on IEPs, because I feel like that's a really neglected area in our community. So we have 5 one-hour training sessions that will teach you how to build that IEP. But right now, you don't know what her needs are. You won't know until after surgery. So the school has to do all of their assessments, right? And then you'll understand whether she does have an auditory processing challenge. It's going to be hard because she's 5. You can't really do it until they're 7 or 8. You should assume she's going to have it if she has a temporal lobe resection.
School that does it, or is it the hospital, or?
For school services, the school has to do assessments. The school must evaluate in all areas of suspected disability. The doctors do medical assessments to diagnose, and they can help the school, but the school still has to do their own evaluations. You missed my session yesterday on IEPs. You should have come to that, because that's where I explain. And I'm happy to walk you through our website if you want to come back to the table, so I can show you, yeah, you always want the school to perform all their assessments, and then you can challenge them with what's called an independent evaluation. Yeah.
I was going to say on that is that we have a neuropsych, does neuropsych testing.
Yeah.
And with the school system, sometimes the school system, when you're in there, he's had one-on-one aids. Someone helps him in the classroom, like break for him and stuff like that. Sometimes the school system will get clever and they'll say, well, we want to be more independent, which is actually like code word, we want to spend the money.
Yeah.
So
Yeah.
you need, when you do the IEP, you need the neuro testing and outside sources to say, no, this is what he needs, this is what you're going to provide. You don't sign on an IEP to make sure your child gets exactly what they need. And they'll try. Some school systems, I'm not saying all of them, but they try. It's all about money sometimes.
Be careful with the don't sign. So you're in Massachusetts, which is what's called a consent state. One of only few in the country where if you don't sign, they can't do anything. Are you in Arizona?
No, we're here.
You're in California, good, another consent state. Other states, doesn't matter if you don't sign, they can still implement the IEP without your permission, and they can file due process against you to force you, yeah. But we're lucky here in California and in Massachusetts. My husband calls it the People's Republic of California for a reason. We get a lot of, yeah. So I thought you guys were in Arizona for a second, where,
Sometimes over
oh yeah, yeah.
And then because he's such an easygoing kid, they're like, well, let's double up on this kid over here with an aid. He doesn't really need it. No, he still needs help. And
Yeah.
it's like a little battle sometimes, so just keep on.
Basically, you would get whatever one, he'll get the weakest one to one because they have the program, like the autism spectrum program that need like 2-on-1s and
Yeah.
challenging kids.
Yeah.
It always seems like he gets the leftover 1-to-1 that's
Right.
left. Because it's pretty easy to, you just need to scribe, you need to make sure he's safe on stairs.
Yeah. Yeah.
And this is, always the risk of coming back. But
Right. Yeah. I'm sorry we're not helping you much. You're an adult.
You are, no, I'm actually a camp counselor for
Oh,
the Epilepsy Foundation Eastern PA. So, yeah, this is very helpful.
oh, good. All right.
We have about 70 kids that some of go through some of them, so it's, information to take in.
Yeah, that's awesome. Thank you. Like I said, this is really hard to do on a whiteboard, so I'm happy to walk anyone through some stuff back at our table. Are you guys, how are you doing with reading? Do you like to read?
we'd like
Yeah.
to
Yes,
Good.
struggle is math.
Math, yeah, that's right. Are you getting intensive math instruction?
A separate integrated classroom,
Uh-huh,
but more teacher to student ratio
right,
in math.
yeah.
So,
Math,
yeah, it's he's sort of getting 1-to-1 in math.
Yeah.
Because there's only 7 or 8 kids in the class.
that's great,
So in math,
that's great.
integrated like civics and a couple of the other classes, but reading, English and math is a smaller class. It's called learning support.
Uh-huh.
So it's a greater ratio of adults to kids.
Got it. That's great. You guys didn't need to be here. You know what you're doing.
Like the vision, you're doing like math, charts and graphs. No matter how many times you tell him his eyes can't pick up the chart, they'll keep handing him the chart.
Yeah.
Over and over.
Yeah,
And they're not grasping. We brought in glasses that are like half and half. With
Right.
C's and try to make them
I'm like, this is
understand.
the way he sees, and they made them put the glasses on.
yeah,
Oh yeah, try to help them out in the classroom. And, how many times you tell them to come back and you'll see a little spatial graph, do it again.
Right.
Go photocopy a textbook and
Pages.
half the size missing.
So you're always kind of on them.
Right. We have a very special guest who just walked in. This is Dr. Gary Mathern. He's on our board of directors. He's my son's neurosurgeon and probably one of the most published authors in the world of epilepsy surgery. He wrote the medical school textbook, or the surgical textbook on epilepsy surgery, and has been part of a couple of our research projects. So you really should be up here. You're making me nervous sitting back there, I'll tell you that much. I'm glad you weren't in the beginning. You would have kept saying, you're wrong. So, yeah, we're very honored to have Dr. Mathern on our board and very supportive of our research on a going forward basis especially. So we're hoping to make the next couple of years just focused on understanding the outcomes and improving them, especially things like constraint therapy, which probably is not a good idea for a lot of our children because one motor strip cannot handle both hands, and you start to take away function from one hand if you work too hard on the other one. So careful there. I'm happy to answer any questions at the table. I just got a notice to stop. So thanks for coming.
All right, thank you.
Yeah.